I want to welcome everybody for attending our webinar for today. Today it's a very special webinar because, as you can see, different specialties is going to talk about a very important aspect. And I know this aspect is, it's a problem that's really showing very clear now in the complications and on the patients coming to our different clinics. It's a pleasure always to have our senior speakers under the Saudi Heart Association in Riyadh. And we are trying just to raise the point where a lot of clinicians are really trying to take care of the proper answer. As you can see, our webinar has a very important question, which is how low we should go. Again, it's we should, it's not how low we can go, because you want to see the scientific information about specific topics. We have our expert, our first speaker, Prof. Khalid Al-Habib. He will introduce for us the important topic, which is the familial hypercholesterolemia. And being his colleague in King Khalid University Hospital, I am Fakhr Zuhair Al-Ayubi. I'm a clinical pharmacist with the head of the pharmacy group in the Saudi Heart Association. I have a master's degree in clinical pharmacy and in the research. I had also a specialist ward in the heart failure. And it's a problem that's tackling most of our patients in different backgrounds. But let us see now the cardiologists who are receiving these patients from their complications. Prof. Khalid Al-Habib, he's a professor in internal medicine. He is consultant cardiologist. He has a very good background in registries and gathering data about different cardiology complications in Saudi Arabia and the Gulf country. It is a pleasure to introduce you Dr. Khalid Al-Habib. Please to talk about the Gulf familial hypercholesterolemia, and please tell us your experience in the coming few minutes. The mic is yours.
Thank you very much, Dr. Fakhr. Pleasure to join you and to join Dr. Saud Al-Sifri. So my talk will be focused on the Gulf FH registry, and we'll leave the management, the diagnostic and management issues to Prof. Sifri. So this is basically going and delving deep immediately into our study, which is called the Gulf FH registry, familial hypercholesterolemia. Just 2 slides as an introduction about the prevalence of FH among the general population and patients with atherosclerotic cardiovascular disease. 2 important papers that came last year back to back, one in Circulation, one in JACC, Journal of American College of Cardiology. And you can see the on your left side, the wall about the different prevalence of rates of the FH in the different regions in the world, ranging from low to high rates, particularly in some of the Asian countries. But what's important in this slide, excuse me, is to show the, to highlight the white color, where many countries in the world do not have actual prevalence rate of FH, and we do not know the actual prevalence of FH. So the other message from this paper is that most of the world data do not, only around 9% actually know, so around 90% do not know the actual prevalence of FH. You can see our color here in the light brown, probably taking the preliminary results from our registry. So the overall prevalence in this study was 1 in 311 FH patients in the general population, making it the commonest genetic disorder in the commonest disorder, similarly presenting across different regions of the world and more frequent among those with atherosclerotic disease. And this supports the advocacy for the institution of public health policies, including screening programs to identify FH early and to prevent its global burden. The other study I was telling you about was published in JACC, meta-analysis of 11 million subjects, again showing in different colors the different prevalences of FH in the different parts of the world, and it shows shown in gray color here the areas where we do not know the actual prevalence. In our region, this study was done before we published our results, so they highlighted our region as unknown. Nowadays, we know roughly the estimation according to the results that I'm going to present today. So the main message behind these two major studies published in the two major cardiology journals in the world, that there are the difference of the prevalence of FH varies dramatically in different parts of the world. It depends on the study design, study methodology, and the most of the countries in the world do not have the actual prevalence of FH. So this is an area that needs more and more studies in many parts of the world. And the study also showed the prevalence depends what kind of population that you're talking about. Again, similar to the previous circulation paper, 1 in 313, but those with severe hypercholesterolemia, the prevalence of FH is actually 23 times higher fold, and 20-fold higher in premature ischemic heart disease, and those with ischemic heart disease, 1 in 31, 10-fold higher. So it depends on the what kind of population that you're studying as well. Do you have any national data about familial hypercholesterolemia in the Middle East region before the Gulf FH registry? The results that I'm going to show you today? Not much. Some single center studies and some genetic studies done by Dr. Faisal Al-Allaf, Dr. Zuhair Awan, Dr. Fahad Al-Nouri, and others, and Dr. Khalid Rasadi from Oman. But really mostly studying families and detecting novel genetic findings, but not a multi-center, multinational screening of patients or populations. So what you're going to see and watch today is the first results ever of FH in the region. Just to give another background, that we think we know that FH and we know how to diagnose it. This is a study done by my colleagues, Muhammad Batais and Turki Mekbil, primary care and community medicine consultants, and doing a survey of almost 300 physicians. And they found that 93% of the participants have poor knowledge of FH once you start asking them, while only 7.1 have acceptable knowledge. The irony is that the majority, almost 70% of physicians, rated their familiarity with FH as average or above average. So physicians believe that they know, but actually, once you start asking them about what's the diagnosis, how do you diagnose FH, how do you manage it, you find a majority actually do not have a good knowledge and awareness about FH. So we have a long way to go as well, not only to educate the public, the healthcare policymakers, but even practicing clinicians. Going into the study, the study design and preliminary results was published in Current Vascular Pharmacology Journal in 2019, led by Dr. Khalid Rasadi, myself, and others across the region. You can find the names here. And the main results of the clinical data, because obviously this involves genetic data as well, that will come later. The clinical results of the Gulf FH registry have been published a few months ago in Public Library of Science, and it's open access, so you can download it for free. The methods, the objectives of the study were to determine the prevalence of FH, or at least to estimate the prevalence according to the Dutch criteria, the DLCN, well-known, world approved and standardized DLCN criteria. There have been many criteria, Simon Broom and others, but DLCN is the most commonly used if you look at many FH studies in the world. So we use this one, which has been well standardized to diagnose FH according to a well-known score, classifying patients into unlikely, possible, probable, and definitive FH according to the score that you're going to get, and to estimate and determine, or rather determine the genetic characteristics of FH patients in the Gulf region, and determine the current management, and to assess the lipid levels and the one-year management of the high likely FH patients. The inclusion were adults patients, so this study did not include the pediatric, so something to keep in mind. So 18 to 70 years of age, nationals only, and LDL cholesterol 4.9 millimole or more, which is equivalent to 190 milligram per deciliter or more, and or total cholesterol more than or equal to 7.5 millimole per liter, which is equivalent to 290 milligram per deciliter or more. And there is a correction formula that we used in those who already having received medical therapy, because many of these patients already on lipid-lowering therapies, and there are well-known correction equations that you can correct for the LDL, and you can recalculate the LDL, assuming that the patient was not on therapy. These are the exclusions, mainly the high triglycerides, the pediatric or very elderly, the non-nationals, or secondary causes. So patients who has one or more history of untreated hypothyroidism, significant proteinuria, more than 1 gram per liter, so i.e. maybe nephrotic syndrome, obstructive liver disease, chronic renal failure or impairment, HIV, or immunosuppressant or steroids or psychiatric medications. So basically, we're trying really to rule out secondary causes and go methodologically to be very rigorous about diagnosing FH. The study went through 4 phases, phase 1 and 2, the ones that I'm going to present today, which is basically effectively in the last 2 to 5 years through their medical records and to assess their lipid profiles, the clinical data obtained through hospital record system after satisfying the inclusion-exclusion criteria, and then subjecting them to the DLCN criteria and classifying them into definitive, probable, and possible FH according to the Dutch criteria. Phase 3 and phase 4 will be reported later on in future sub-studies, where we are planning to look at only 500 patients with those with definitive and probable FH, and go into the deep genetic testing of the 4 FH genes. 95% of the, or more actually, of the FH genes lie between these 4 genes: LDL receptor, ApoB, PCSK9, and LDL-RAP1. And then trying to follow these patients for 1 year for their outcomes. Quickly about the sample size. How did we estimate the prevalence, the sample size, estimating the prevalence of FH? This table shows the first the national population in each Arabian Gulf country, the expected prevalence of FH, heterozygous FH in each country. If we take the prevalence of 1 in 500, which is a conservative prevalence, many of the recent studies, as I have shown you, that the prevalence is more than that, is 1 in 300 or 313. The prevalence might be actually more. These are the expected number of patients in each country. And then we thought if we take a snapshot rather from each country of around 10% sample size, that will get us around 5,000 patients. If we get around 70% or more from this number, that would be great. So at least we get a good snapshot that will be representative, hopefully, of the FH prevalence in the region. The results, we enrolled the 14 major tertiary care hospitals that across 5 Arabian Gulf countries. These major tertiary care hospitals do not only take care of their own patients, but they take referrals from surrounding hospitals and even the whole region. So their care not only represents their own patient population, but referrals from in different clinics, primary care, endocrine, cardiology, what have you, from the whole areas and districts around them. And we screened a huge number, over 34,000 patient records retrospectively that attended various outpatient clinics. We tried to look at different clinics, endocrinology, primary care, nephrology, cardiology, and so on. So we avoid bias in the recruitment in the last up to 5 years in the past. This table shows the overall sample size that we ended up from the screening over 34,000 patients. In green color, it shows that we boiled down after excluding many patients that did not fit the criteria to 3,713 patients. And once you subject them to the DLCN criteria, They get classified into unlikely, possible, and probable, and definitive in the orange color. And you can see the percentages here, 12.8 in the unlikely. Most of the patients were possible, 75.4, and 11.8 were probable / definitive. We lumped those two groups together. You can see, first of all, the average age is around 50, and pretty similar across the three groups, while the probable and definitive are slightly older. So this is the first message, that basically these patients who are probable and definitive, their average age is 50. You would imagine that this is kind of a genetic or inherited disease. You would discover patients in their 20s or 30s. They are in the 40s and 50s. And this is a message and a clinical message that has been shown again and again in different studies, that these patients get diagnosed late in life, unfortunately, in their middle age, 40s and 50s. So they pass through long years and years of being misdiagnosed or underdiagnosed. Female gender were around half of the population, smoking 7.5%. And you can see here the probable / definitive patients. They're more likely to have history of FH, more likely to get genetic testing, more likely to get tendons and adenomas and arcus cornealis, which is expected. The first major finding of the study, and one of the major objectives, is that according to the probable and definitive only, according to many studies, that they lump together these two, and according to the estimated prevalence here is 1 in 112. So according to this finding, the prevalence of FH in our region is almost 3 times higher than the world reported prevalence of FH of 1 in 300. So our prevalence is way higher than the world reported the prevalence of FH. How about other diseases that they have? The prevalence of coronary artery disease risk factors were similar to the general population. So diabetes is around 28%. And in the definitive and probable, it was actually slightly lower, 23%. Some studies suggest that maybe patients with FH are protected genetically from diabetes, although this has to be really explored further in future studies. You can see the prevalence of other risk factors were actually similar between the unlikely and possible, but higher consistently in the probable and definitive compared to the unlikely and the possible. And the same goes along with the prevalence of the history of PCI, 19%, and those with probable and definitive, CABG, 11%, and so on. So these are sick patients. These are patients who really have premature coronary artery disease. How about the management? The most commonly used statin is atorvastatin. Almost 50% of the patients got atorvastatin, followed by these percentages in other statins. And the other major findings in the study have the statin intensity. Shown in blue color, the low intensity of statin, orange color, the medium intensity, and green color, the high intensity. And you can see across the different groups that being classified by the Dutch criteria, that almost 30%, one-third among the receiving low, medium, or high intensity. But the probable / definitive group, they are way higher, almost 60% received high intensity, better than the other group. But I would have expected this very high risk group to be in the 90% or more. So this is still undertreated patients. Despite receiving statins, they are undertreated with the low intensity of statins. How about other therapies? Mainly ezetimibe, PCSK9 inhibitors, and LDL apheresis. Ezetimibe was used overall in 10%. In the very high likely FH, probable and definitive, again, only 33%, only one-third received ezetimibe. PCSK9 was only 0.4% across the whole groups. Again, probably reflecting that the uptake of PCSK9 inhibitors use was still slow, taking into account that the study was being conducted during the approval process of PCSK9 inhibitors into the region, and the uptake probably was very low by then. LDL apheresis was very low, was 2.8% in the definitive and probable group. How about the lipid profile? This is the total cholesterol, LDL, and the non-HDL cholesterol. You can see here the baseline and post-index. And focusing here on the levels in the probable and definitive, you see extremely high level, 9.5 total cholesterol to going down only to 7.1, and the LDL from 7.6 going to 5.9. Again, not a surprise, taking into account the very small, the average or the low use of high intensity statins and other therapies such as ezetimibe and PCSK9 inhibitors. So no wonder that really not much of achievement in the LDL targets. And this is shown according to the, if you look at the ESC guidelines, the 2016, and these are the targets for the LDL cholesterol and the non-HDL cholesterol, shown here in high-risk patients of FH, meaning FH only with without much of atherosclerotic disease or coronary artery disease risk factors. Once the patient of FH have atherosclerotic disease or coronary disease risk factors considered to be very high risk, so the target will be much lower, 1.8. And you can see here that the high-risk FH patients, the achievement of LDL target according to the guidelines is only 12%, and the very high risk is only 3%. If you look at the 2019 guidelines, which is basically came almost at the end of our study, to be fair to our clinicians, the achievement is extremely low, would be in the range of 1% or less than 1%. So we have a way to go to really to achieve the target in such patient population. How about to finish the limitations and the strength? The limitations of our study, it's still a retrospective study, so we might have faced a lot of missing data, possibility of misclassification. Are we really truly, is our estimate is really the true prevalence of FH? You can argue either way. You can, is that an overestimation of prevalence because of referral bias of sicker FH cases or severe, more severe cases being referred to the tertiary care hospitals? This is possible. Or are we actually underestimating the prevalence? Remember that we did not include pediatrics in the study or even do a cascade screening, i.e., once you identify the index case, you go into the family, which by definition basically will make you discover more and more cases of FH patients. Strength, this is the first of a kind in the Middle East region. At least now we have data about FH, and we have a kind of an impression about the prevalence of FH and the management in the region. You can argue, actually, this is the first time that some group of scientists actually did a rigorous study protocol and followed a very rigorous protocol of inclusion and exclusion criteria to avoid secondary causes. This is a multi-center study in 5 Arabian Gulf countries. It took a lot of time, a lot of effort, and a lot of really years to come down to this point. It involves clinical and genetic data with 1-year follow-up. So stay tuned for more genetic data in the next few years to really discover novel mutations and to describe the genetic background in these kind of patients. So to conclude, Dr. Fakhar and Dr. Saud and ladies and gentlemen, the Gulf FH Registry is a first-of-a-kind multinational study in the Middle East region. The prevalence of FH in the other population of the Arabian Gulf region is very high, about 3-fold the estimated prevalence worldwide. Is it because of high rate of consanguinity that goes up to 50% in our region? Some people argue it should not because it's an autosomal dominant disease. Is it because of what's called founder effect? FH patients are undertreated and low proportion achieve the target cholesterol targets. Gulf FH Registry will potentially help in improving the gap of underdiagnosis and undertreatment of FH patients in the region, and there is an urgent need to implement nationwide population screening programs, raising FH awareness, and improve management strategies for FH patients, which will be the topic of Dr. Sifri to tell us about the latest innovations in such area. Just to highlight one study before I leave, that our results have been included in the recently published Familial Hypercholesterolemia Studies Collaboration, the FHSC, that was published in the Lancet. So our results was part of an international study that was published in the Lancet, including many countries in the world, screening almost 40,000 patients or more in different countries in the world. And again, showing compatible with our results, the very low achievement of targets, LDL, in these kind of patients. To conclude, would like to thank you and to thank the steering committee and the many patients that were included in the study. Thank you very much for your kind attention.
Thank you very much, Prof. Khalid, for this informative presentation. It's always important to focus on the problem before we try to solve it. So it's at least it's a glance to what's happening in our culture. And I think that would really take us to Prof. Saud Sifri, where we really need to know about the medications and the treatments and what is the future of hyperlipidemia in familial hyperlipidemia patients. We will take the questions after Dr. Saud talks, so please put on your questions in the Q&A box. And I have a few questions to ask later, but let me now introduce Prof. Saud Sifri. He is a professor in medicine. He's a consultant endocrinologist. He will take us to another view about the same patient. How do we look at them? And he is the head of the endocrine department in Al-Hada, Al-Taif, another region in Saudi Arabia. Again, that's what I'm talking about, different views from different aspects. The mic is all yours, Prof. Saud. So please go ahead and start with your presentation.
Thank you very much. Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Fakhr. That's really a pleasure that I'm with you in this with the experts like you and again Prof. Khalid Al Habib. Thank you very much. I think what we have heard from Prof. Khalid was really something that we should be proud of. Now having at least a local data where we can at least start from or build on, that's really a fantastic job. It has been done. So always to put a foundation is always a very difficult. Now again, I'm going to take you from where we have ended. So we have came a conclusion that we have got maybe a higher prevalence than what we would expected. And I think we would go back into, is it really underdiagnosed and undertreated? And over this, I would take you through a very good news that we have got a very good advancement in the management of familial hypercholesterolemia. So in this, I think this is basically what we wanted to talk about. We're talking either about heterozygous or homozygous FH. And here it's always about mutation in the gene. Here where the most common identified mutations in the genes are either related to the LDL receptors, which is on the hepatocytes, or apolipoprotein B, or the BCSK9 gene mutations. Now, this would not allow the LDL to be internalized inside the hepatocytes and then get removed from circulations. And that would leave almost more than 50% of those, let's say, functional LDL receptors in order to remove it from circulations. And that would lead to accumulation of the LDL within the circulations with their consequences, atherosclerosis, and then having multiple defects that always would be identified. I'll just try to find out using the laser pointer so that it would be easier. Now this is, I just want to start with this. Would you imagine this patient, this goes back to 9 years. This was in 2012. He came to my clinic and he's a 14 years old boy. And at that time, he was struggling for the last 3 years. So would you believe that somebody is having like this? He went initially, he had a tendinxanthoma, and that was at his leg. He went to orthopedic where it has been removed. And then 1 year later, he developed this elbow xanthoma and then referred to a dermatologist. And then dermatologist was so clever enough to refer him to me. So he had been suffering for the last 3 years, moving from one to the other. Now, before he came to me, he has visited many physicians. And just to tell you that the most striking thing in his history, that he lost 3 of his brothers, and all of them, they were between 20 and 30 years of age. And when he was at that age, he said, I'm afraid that I'm going to die like them. So this tells you that even with those, I would say, a very clinical pictures, still we are missing them. And this is what we wanted, that always we should have a very high suspicion for these cases in order to reach a right diagnosis and then to give them the right management. So it's not right to start about management without knowing how we would suspect in these cases. So in this, I would go very, very quick. Now, screening has got different criteria. Some of them came from the European Society of Cardiology. And again, if you would see, some of them depends on clinical pictures, like tendinxanthoma, or other like clinical feature, either a premature coronary heart disease or a sudden cardiac death, or things which is related to family history, or others which is related to, let's say, laboratory results of lipid level. Now, Dutch, which is most commonly one, again, it depends on family history, and then the clinical history findings in patients, and then the physical examination if you find, and then the lab results. So all of them has got different scores. And based on this score, if you got somebody who has got a score of more than 8, for example, if your patient has got, let's say, an LDL, which is higher than 8.5, by these criteria, he is definitive FH. Now, if you have got somebody whom you could do DNA testing, in that situations, definitely he is going to be a definite FH. Now, other less scores, it goes from probable into possible and then unlikely, as we have seen from the protocol study, which we have heard from Prof. Khalid. Now, semen prone is another criteria that, again, sometimes it is used. But the main thing, always remember, it depends on family history, lab results, and then the clinical pictures. So if you put all of them together, definitely you would suspect, and based on that, you're going to diagnose. Now, again, nice, they have put their way of diagnosing. And again, it depends on semen prone criteria, and all of them, they have suggested if you could offer them a DNA test that would confirm your diagnosis, and then based on that, you would go. Now, for children who has got this, definitely DNA test is always an essential part in that one. Now, should we go with the clinical diagnosis or should we go with the mutation? I just want to tell you here, there are few cases. Now, here we are talking about 10 to 20%, and here another 10 to 20%, where here, for example, you've got, let's say, an index case, and then when you screen the family, you found a mutation, but that member of family does not have the clinical features. In that case, the only thing you would do is just to monitor them. Now, the second scenario is those 10 to 20% whom they have got all the features of FH clinically, but when you go and do a mutation, you don't find. In that situation, you treat the patient, and then you might not do a gene or DNA testing for the family. Now, in most of cases, luckily, that we could identify the mutation along with the clinical diagnosis, and that would lead to screening the whole family, and that might lead to identifying those cases. Now, this is just a summary, just to show you that, again, when to screen, and with this, that we can reach a diagnosis. And then always we would depend mostly on those most accreditable criteria, which is the Dutch Lipid Clinic Network criteria. And then we have to always to exclude other secondary causes of hypercholesterolemia, which has been seen in Prof. Khalid presentations. And after that, if you could do for the index case and DNA testing, and then for the family member cascade screening, that would be fine. Again, lifestyle modification is one of the pillars we would use, but unfortunately that you don't expect much reduction in that. Now, for the treatment, again, we have got dose, maximum tolerated dose of statin is always the gold standard. You could add ezetimibe or others. Now, this has been before the introduction of those, I would say, monoclonal antibodies or the small interfering RNA novel treatments. Now, again, with this, in those homozygous, where always we would need LDL apheresis in those patients. Now, this is just to show you that, again, our aim is not totally different as it has been identified in the previous presentations, that always we would look for, after starting or putting patients on the high maximum tolerated dose of statins, we would try to achieve at least more than 50% of LDL reduction, or in that situations, at least less than 100. If still you could not achieve that one, then you could add ezetimibe or PCSK9 inhibitor. Definitely the main limiting, I would say, in this process is really the cost that we have to consider in treating them. Now, one of the problems, if you would see that always we say high intensity statin, and if here in this study, which we talk about almost 500,000 of people who had started either on high or moderate intensity statins, you would find that almost after 12 months or 15 to 20 months of their starting treatment, you would find more than 50% of them, they have discontinued their statins. Now, why is that? We don't know. It could be different explanations. It could be adverse event related to the statins, or non-compliance or non-adherence with those chronic medications where they have to take it every day. Now, one of the things that it has been noticed in this meta-analysis, they looked into those and they found that those who had been on high-intensity statins, they stayed longer on the statin treatment before they discontinued. So it might be because emphasis on this has been maybe from their HCPs on this. Now, again, PCSK9 inhibitors are very important in those. And if you would look into more than database of more than 6,000 patients who had started PCSK9 monoclonal antibodies, you would find almost that 50% of them, they have stopped their, or they had an interruptions of their treatment. Now, again, if you look into all their lipid-lowering therapy, whether it is PCSK9 monoclonal antibodies or other like statins, you would find 44% they have got their interruptions. So it tells you that, again, we have got a high proportion of patients who might not be very adherent or compliant to treatment. It could be because of the frequency or the adverse event related to the treatment. Now, in this, we would go into now, what do we have as emerging therapy for reducing the LDL, in particular in those patients with, I would say, atherosclerotic cardiovascular disease, where they are very high risk patients, and the other populations, which is the heterozygous FH. And in those, we have got two molecules, the inclisiran, and inclisiran is really one of those small interfering RNA therapy, which really directed towards hepatocytes, and it caused an increase in the LDL receptors on hepatocytes so that it can have more uptake of the LDL from circulations and to be degraded within the liver. Now, the other thing is bembudic acids. And with this bembudic acids, again, it inhibits the ATP citrate lyase, which really works similar to statins, and it has got almost 30% reduction in the LDL once it is used in those populations. Now, I would go into a little bit in details using this novel molecules in which inclisiran is used. So it is a small interfering RNA, which has got first and the utilizations of this siRNA. Now, just to show you that how LDL is degraded within our system. That, remember, these are the hepatocyte surface, and then the LDL usually is attached to the LDL receptors, and from there it goes internally into the endocytes, into the lysosome, and then it gets degraded. Once that LDL has been degraded, what would happen to the LDL receptors in normal populations? It goes back into the surface, and then again, it would transport, or it would be attached to another particle of LDL and then bringing it down. So the main thing that LDL receptors is recirculated. So it goes down inside the lysosomes, and from there it goes into endocytosis, and the LDL particle will be degraded, and the LDL receptor will go back into the hepatocytes and pick up another one. So it is a way of, let's say, transporting LDL from circulations into hepatocytes, lysosome, where it degraded. Now, in those genetic mutations, what happens? Either the LDL receptors, if they have got a mutation in that, you would find a small particles of them. So what happens once this, let's say, particle of LDL along with their receptors goes inside, both of them, they get degraded, and that would lead to a reduction in the LDL receptors. So they cannot bring more LDL from circulations into liver. Now, the other, it could be a mutation in the PCSK9 gene, and with that, again, that protein could bound to LDL receptor and can inhibit or decrease their availability on the hepatocyte surface. Now, the inclisiran is really the double-stranded small interfering RNA, and with that, it increases the LDL receptors on the hepatocytes. So by this, we are providing more and more free LDL receptors in order to get attached with the LDL and then get it and degraded in the liver. This is very small, just to show you that once the inclisiran binds to the hepatocytes here, it gets into endocytosis, and then here in the cytoplasm and the endoplasm, it goes slowly and it is released from there, and that would leave more and more of the LDL receptors goes back into the surface, and that it could attach more and bring it down. So this is in a very simple way. So we are giving more and more of LDL receptors in order to this. Now, PCSK9 protein is always interfering with let's say, the complex of LDL particles and LDL receptors. And with that, it would not allow detachment of both of them. And that would lead to degradations of both the receptor as well as the LDL. And what would happen as a final result, you would not find more of LDL receptor at the hepatocyte cells. Now, the inclisiran, what does it do? It would inhibit the PCSK9 protein production, so that the PCSK9 would not have the capacity to be attached with the complex LDL receptors, and that would leave more and more space for the LDL receptors to go over the surface and bring more of them. So from here, the mechanism of action of inclisiran, again, it is the only therapy which is using the siRNA mechanism, and that it would lead to significant LDL reduction. And again, it mimics our RNA, and with that, it would increase the receptors of LDL in the hepatocyte, and it would increase more clearance of LDL from circulations into the liver. Again, the mode of action of inclisiran, it is very effective in those, and again, it could lead to a more sustainable use of inclisiran over a longer period of using or dosing interval. So we could use it up to every 6 months. Now, ORION is the clinical development program of inclisiran, and you could see that in phase 1, phase 2, and then phase 3. Some of them has finished, and others are ongoing trial because they have got an extensions. Now, since we are talking about heterozygous FH, we are going to concentrate more on this or leave others, because in that one, it looks into all kinds of populations where we are talking about patients who has got either atherosclerotic cardiovascular disease, what would be the efficacy of inclisiran in that, and then other who has got risk equivalent of atherosclerotic cardiovascular disease. And with that one, we wanted to see what would be the efficacy. And again, it looks into different populations, those with renal impairments or with hepatic function impairments. So in all of this, they have studied all of those studied. Again, they have looked into patients with homozygous FH. And again, all of this completed or ongoing clinical development program of inclisiran looks into their efficacy in different kinds of populations and clinical situations, and looked into their safety and what would be the features of them. Now, again, there are few trials which has been finished and then it got extended, and the aim of that is really to study it over a longer period of time, which is almost over 2 years. Now, worth mentioning that one of those major cardiovascular outcome trial is ORION 4, which included more than 15,000 patients who had a previous myocardial infarction or peripheral arterial disease or stroke. So they wanted to see what would be in the clinical outcome in terms of their output. The renal impairment, this is ORION 7, and the good thing, they have looked into 30 patients. They wanted to see whether there would be an, let's say, the same efficacy in those patients who has got normal or mild, moderate, or severe renal impairment, and could be, and is there any adverse events or toxicity from this? The good news that it was very safe, and with this, the area under the curve was increased, and despite this, they have got very similar efficacy, and it was safe without much toxicity in those severe renal impairment cases. I'll just go briefly over ORION 9, which looked into this populations, which is heterozygous FH. And again, those are the investigators. And with this, we wanted to see in those populations, as mentioned by my colleague, Prof. Khalid, that more than 90% of those populations, they go because of LDL receptor gene mutations or their PCSK9 gene mutations. Again, in their managements, always we depend on high tolerable dose of statins, ezetimibe, and then looking into monoclonal antibodies, PCSK9 inhibitors. These are the inclusions, so all of them are adults. And with this, they have used Simon-Brown criteria or genetic testing in order to identify homozygous FH. Again, they had been maximally using tolerated dose of statin, ezetimibe, and then their consent. Now they have excluded some others who has got either using PCSK9 before that, or others who have been either contraindicated like pregnancy or nursing ladies. These are the schedule of visits. So inclisiran was given 300 milligram, and usually once we give it, the first dose we give it after 3 months, and then we maintain it with every 6-month dose of inclisiran. These are the visits. So the visits has been extended almost up to 1.5 years, and then extended for another 90 days after receiving the last dose, just to look for adverse events after treating them. Now screened more than 600 patients, and they have randomized 480 into two. Either they would receive placebo in top of standard of care, or inclisiran every 6 months based on top of standard of medical care. Now just remember, and this is really the good thing, that those who completed the study of almost, I would say, of almost 1.5 years, they were 96% or more. And this is a good in order to look for those who had received the treatment. These are the baseline characteristics of patients. So their average age was around 56, and half of them, they were male, while the other female. And those who has got current disease of atherosclerotic cardiovascular disease were around 1/3. And then more than 90% of them, they were receiving the high intensity tolerated dose of statins, and ezetimibe are used in 50%. And this is their baseline LDL, which is, we are talking about almost 150 milligram per deciliter. And from here, I just want you to remember now, these are almost, I would say, well-treated populations, because they are receiving high intensity dose tolerated of statins plus ezetimibe. And despite this, again, their baseline HbA1c was 100, LDL was 150. So we are talking about populations well-treated, and even their baseline LDL starting from is around 150 milligram per deciliter, which is not very high. Now let's see what happens to their efficacy. Now this is the population which received the placebo on top of standard of care, and here those who received inclisiran on top of standard of care. Now look after 3 months, what happens with those? They have got a reduction of almost 40%, and this has been continued, sustained, and you would see at the end, there was a difference of 50% of LDL reduction for those who received inclisiran compared to those who were on placebo and standard of care. So it tells you that really, even following them for almost 1.5 years, showed that, again, 50% of LDL reduced by using inclisiran in those populations. Now, this is very interesting, because we have seen that the most common one is the LDL receptor mutations, but again, ApoB lipoprotein mutation is another one, and then PCSK9 inhibitor, PCSK9 gene mutations, whether it is either loss of function or gain of function, but here gain of function, which means that they have got very high risk, and those who had not been identified. So they wanted to see the inclisiran, is it affected by the gene mutations that they have got? And the good thing that in average, we have got almost like 50% reduction by using inclisiran in those different variants of LDL of gene mutations. Now, how about safety? This is just to show you that overall there was no difference. So here, once we talk about those treatment emergent adverse events, we're talking about 70% in both inclisiran and placebo. Now, none of them were different from placebo. They were equal, apart from here, once we look into the injection site reaction. Here it was like 9% compared to almost 0. And this is expected in those. Now, while others were not different from placebo. Now, in this injection site, we wanted to see what happens. Now, the good thing that if you would see, the majority of them were mild, and the good other thing that it was transient. So with the time, it goes out. None of them had been severe or persistent, which was a bit reassuring in those populations. Now, how about their effect on other liver enzymes, kidney function, and others, platelets? There was no difference between inclisiran and placebo, and that gives us more reassurance in those populations. Sorry for that. So in summary, Orion 9, which looks into populations of heterozygous FH, did not have any much difference in those. And the good thing that more than 50% reduction of LDL over those 18 months, and then again, it has been used in those well-treated populations, and the reduction was independent of the underlying FH genotype or mutations. And again, it was very safe, tolerated, apart from injection site events, which was around 13% in inclisiran, and that was mild and transient in those cases. So I think this is, again, another thing to remember. Now, the good thing that inclisiran is given 2 doses per year, and it has got very strong complements to statin to achieve sustainable and effective LDL reduction. This is from a pooled analysis of all Orion program to look into their efficacy and safety. So in this, in terms of efficacy, if you talk about those who had got mutations within their PCSK9 gene, you would find that the reduction by almost 18 months was 80% of LDL, while in the average, it was more than 50% in all populations. And again, those were, if you would see, in most of populations, they have achieved LDL of less than 55 milligram per deciliter. Now, again, on their safety, there was no emergent safety alarm. And the good thing that there was no much difference between placebo and inclisiran in those populations. I would like just to finish with the final slide that, again, FH, I would just conclude with the same statements of Prof. Khalid, that it is underdiagnosed and undertreated. And I think screening is always indicated in those with a total cholesterol of 8 millimole. So don't go much. If you have got the facility of genetic DNA testing, that would be a preferred way. Always statins remain the gold standard of treatment in those. And in other patients, especially if you talk about homozygous FH, then LDL apheresis is another. PCSK9 is indicated in those FH who did not achieve their target. And then now the novel treatment with inclisiran is very promising in LDL. And I think in those 2 populations, those with heterozygous FH and again, atherosclerotic cardiovascular disease populations. And we have seen from all these efficacy and safety trials that inclisiran provides an effective and sustained LDL reduction with 2 maintenance dose per year. Thank you very much, Dr. Fakhr and my colleagues. Thank you very much.
Thank you very much, Prof. Saud. Very nice presentation and very informative. And because we have a few minutes just left and we did not still finally answer the question, that's why our next webinar will be coming very soon under the sponsorship of Novartis, which is the series of how low we should go. But I just want to catch up with a few questions. Maybe I'll start with the first one with Prof. Khalid. They are telling us what's the picture of treating familial hyperlipidemia in Saudi Arabia. Let us talk first about the cardiology point, then we'll take the endocrine. What is the picture of treating familial hyperlipidemia in Saudi Arabia?
Yeah, as I have shown you in the Gulf FH registry, there are several countries, including Saudi. Saudi Arabia representative of the sheer force of the on the majority of patients enrolled, followed by Oman. So probably not much different. We did not. I did not show you the different management as per country. I don't think it will be way different or much different from the end result. Extremely low achievement of targets of FH, target LDL rather, in FH patients because majority of patients in the registry was from Saudi anyway. So I don't think it will be much different from the overall result. There was a question from the audience as well asking about the target. What is the target LDL in these patients? As I have shown you, according to European Society 2019 guidelines, just having FH by itself without anything else is basically demarks the patient as a high risk, which means that the LDL should be less than 1.8 millimole per liter, which is extremely low. FH with coronary artery disease risk factors or with coronary artery disease, atherosclerotic disease, the LDL should be less than 1.4. So one of the major struggles in the clinic when we see these patients is to tell them lifestyle by itself is not going to do it. It's not going to make it. It's good. You have to do it, but you really need strong therapies and multiple therapies. In fact, I start combination therapy immediately. I don't start with the highest dose statins only in these patients. I usually start with combination with ezetimibe, see them in 2 to 3 months, and then assess if they're still not achieving the target. I add PCSK9. Now having inclisiran as shown by Professor Sifri, the question is whether actually to use now inclisiran to get sustained effect over the whole year rather than PCSK9 inhibitors. So that would be the major change in the clinical practice that we're looking for.
Professor, do you have anything to add? Because we get the patients after the complications. What about your clinics?
Yeah, again, it is the most difficulty we are facing is really in diagnosing cases or suspecting cases, because most of our patients, they have been referred from primary care or family medicine clinics. So always they come very late. And I tell you that some of them, they would come after their first event. Now, luckily, if we would find like patient like that one who come in there, always we would do the same as Prof. Khalid said. We would start combination from day one in those suspected cases with a very high, and then usually within 8 weeks, if no response, then we go for PCSK9 after having full identification.
That will take me to the question that is also by our audience. After we start the medications, and now I think what they're talking about specifically is the Dr. Saud?
I don't think we have the answer. So for inclisiran, still we don't have that belief that in patients who has got an interruptions in their treatment, regardless of this, whether it is a statins, PCSK9 inhibitors, or even LDL, would expect that they would go into the same, because we are not treating. We are treating, but we are not curing the disease. So I think they would. What I would
with this, or do you want to add?
Sometimes the clinicians get frightened for 0.5. I've seen people with 0.05 and 0.01. During the session is these people have their LDL of 5.5. They have been exposed to this LDL all their years since their birth. So this is a major concept. So their risk is different from yours or mine or whatever in the general population. So some doctors think that they're gonna find all these xanthomas and xanthelasmas. The majority of them are heterozygous FH. This is the one in 112 that I have shown you in the registry. So almost every 100 patients that comes to your clinic, one of them will have FH, and he or she might not have any cutaneous findings. So clinicians are always wired, and their mentality are only toward homozygous FH. It's 1 in 1 million. It's rare. No, this is wrong. This is homozygous FH. The heterozygous FH is actually the commonest genetic disorder, and you might not have any xanthomas or xanthelasmas. And the only suspicion is that LDL more than 5, or as Professor Sifri mentioned, their total cholesterol more than 7.5 or 8, whatever criteria you want to use. So once the patient's LDL is 7.5 or 8 or more, this is FH proven otherwise. And as he has shown you nicely from that slide, they might actually have negative genetic mutation. So even if you do not do genetic testing, don't feel bad. treat them as FH till proven otherwise.
That will take me to maybe our final question, which is, what is the group of age that we should really look at for FH?
Well, yeah, that begs the question is then, if we talk to the Ministry of Health, what kind of screening methodology we should be doing? If you look at there is a major initiative in Europe called FH Europe, and basically trying to learn from the success stories in different countries. And many countries now implemented screening in the pediatric group, what's called opportunistic screening. So whenever they come for their vaccination, لقاح اللي ياخذونه في الأطفال, pre-marriage screening for their LDL. So if I'm gonna advise as a clinical level or even at the Ministry of Health level, just doing a cholesterol profile, these regular visits of your child, particularly in a family that have premature coronary artery disease. I mean, sometimes you find patient يقول لك اخواني كلهم جاهم لسه امس شايف مريض يقول لي مريضه قالت لي اخواني كلهم بابوي يعني they all had coronary artery disease and heart attack and some of them died in their 40s. You really need to suspect FH and screen all the family and the relatives. This is the starting point. Very worrying family history. Two, opportunistic screening. So whenever you have a child, as in the pediatric level, probably or pre-marriage, at least do an LDL or total cholesterol. That will be your starting point.
Great. Professor, do you want to add any point before we end the webinar?
No, I think I just concur with what Prof. Khalid said, that always in those, we have to have a very high suspicious index for them. If you don't suspect, you cannot diagnose. So again, this is a message to our colleagues in whom they are seeing the vast majority of people, always suspect. So he might come to you for example, for hypertension. But if you would see his xanthoma, or you would suspect that you would find his LDL is more than 5 or total cholesterol more than 8, please either do something or refer him for somebody else. So thank you very much.
So the treatment of familial hyperlipidemia, would you suggest to be with endocrinologist for a patient who's planning to get pregnant, or cardiologist, or whom should take care of her? That's an alarming question that we really need to answer.
If you would allow me, I would say most of those patients are treated with cardiologists because most of the time their first diagnosis comes with their first event, which is with our colleagues. So those who are still without events, I think they could be managed with endocrine. But those who developed already a disease, they would be treated with our colleagues.
And the dream is basically we reach to a level that our primary care and community medicine actually pick up these people early on, and with inclisiran, it becomes like a vaccine. You give it 2 shots per year in addition to the statins, and bingo, you get to the target immediately. So I think that would be the vision, rather than reaching to the experts, the endocrinologists, the cardiologists. By that time, it becomes too late. I've shown you the average ages in the 40s and 50s. Which has been shown internationally. We do not wait till these people get detected in their 40s and 50s. We want to detect them very early on in their life.
Great. Thank you very much for the audience who were with us in Fridays, which is the weekend for them. But it was a very enjoyable talk. Thank you, Prof. Saud. Thank you, Prof. Khalid. There was a question for our next webinar. Who are the candidates for such a medication? And that would be tackled in our next webinar. That is will be sponsored with Novartis, and it's under the umbrella of the Saudi Heart Association. Thank you again, and see you very soon. Take care.
Thank you very much.
Dr. Fakhr, for your activity and for your invitation.
Thank you very much for the kind invitation. Thank you for being with me.
Thank you.
الله يعافيك. أراكم على خير قريبا إن شاء الله. في أمان الله.